Hello, hello. Happy Thursday, everybody. Welcome to yet another VMR. Um, I'm really excited to be joined from across the world today with my dear friend Bettina, who's co-discussing with me. Bettina, hello. How are you?
Hi, Robbie. I'm good. Thank you so much for accommodating the time zone
Oh no,
today.
not at all. This is like as Reza often says, this is lunchtime for me. I've been awake for a little while, and thrilled to be sharing the stage with you. Bettina, tell us, what have you been up to since you've been joining CP Solvers? What has it been like for the last few months for you?
Oh, it's been incredible. So I do a lot of different things. So one of my favorite things is doing the teaching points in clinical problem solvers. So I think maybe that's where most of you have seen me. But behind the scenes, I also do some stuff like I upload the episodes on our website, and I'm also part of the case review committee, which is really fun.
Oh, Bettina, you're too humble, way too humble. Bettina has been a star since she joined the CP Solvers. Been about 6 or 7 months now, Bettina. Um,
Yeah.
And it's amazing what you've accomplished in such a short period of time. And you're right, a lot of it is unnoticed and goes behind the scenes. But Tina and Noah are the reason that we all maintain such a rigorous attachment to VMR with your very detail-oriented uploading. But truthfully, Bettina has discussed in 3 or 4 other spaces outside of these Thursday facilitations, and I'm always in awe uh, of your clinical reasoning, Bettina. In fact, I think you're being a little bit too humble about your role in the case review committee because there's a big announcement coming soon that Bettina is keeping quite the secret about her role in the case review committee. And that's just one way that we've been so grateful to have you as part of this team, Bettina. You really have made such a tremendous impact, and we're very grateful for it. Um, I also want to welcome our case presenter today, round two. Like Bettina, somebody who I've known for quite some time, a lot longer than 6 months. It feels like 6 decades, Dr. Weber. Hello.
Good morning. I'm happy to be here.
Tell us a little bit about yourself before we jump in.
Oh, yeah, sure. I'm a second year fellow at UCSF where I also did internal medicine residency. And I don't know, what else is there to say? I have a 3-year-old daughter. And
I'm glad you snuck that in. That's a very important statement. An incredibly wise 3-year-old daughter who has a character like no else. It's been really cool to see her grow and blossom.
yeah.
Um, just for context, because Dr. Weber and I may poke each other more than you may notice other case presenters. I first met Rob when he was a acting intern or an MS4, and got to be his attending on the wards. And he is literally the only fellow that I know who makes it a point to come to VMR regularly, which goes to show you that his just the level of dedication that he has for clinical reasoning. So, Rob, thank you so much for joining us. I'm a little excited and a little nervous, but thrilled to be with Bettina today. So whenever you're ready, we can jump right in.
All right, let's do it. Yeah, don't be nervous. I'm going to start the case similarly to yesterday's case. So, Alcoa 1 is a 57-year-old woman with breast cancer, presents to her primary care doctor with polyuria and polydipsia.
I don't know if you were there,
Okay.
Bettina, but deja vu a little bit. What are you thinking?
Right. So when I'm thinking about polyuria, I'm thinking at maybe first is that does the patient have an increased level of a substance that is causing increased diuresis, or is the patient taking in too much water that's causing the polyuria? So in our patient, the patient also has polydipsia. At the same time, I'm also thinking about, is the patient having a deficiency with the antidiuretic hormone that may have a lot of other causes after that, with central or peripheral or nephrogenic. And then with polyuria and polydipsia, maybe the first thing that comes to mind, honestly, is diabetes. So that's something that I would want to make sure that the patient is not having, and especially want to check the glucose specifically, and to see if the patient has any other associated symptoms that can help us clue in towards our differential diagnosis. So I'm curious what you think about this, Robbie.
I have nothing. You have nothing left for me to add. That was absolutely superb. I think all those thoughts are on my mind. Um, since since you made such tremendous progress, I think it's probably a good idea to sit and reflect for a second on what the difference is between the combo of polyuria and polydipsia versus polyuria alone, because just to be explicit and to iron out our thinking, the differential diagnosis you outlined is a superb, both comprehensive but also practical way to approach polyuria, right? You're saying the patient could have diabetes, could have primary drinking too much. I'm curious in your mind, what would be different if the patient just said they have polyuria and did not mention that they have polydipsia? How would that change your calculus, you think?
Right. Probably I would include more of the urinary causes, like
Yeah,
especially UTI would be
super.
on my mind.
Exactly. I think that the presence of polydipsia confirms that the diagnosis is in fact polyuria. And if we're trying to be very strict about what these terms mean, polyuria means the patient is urinating more than 3 liters of urine per day in 24 hours. But there's no way that a patient comes into your clinical space having measured how much urine they're making per day. So all they really know is that they're urinating a lot, which might be a lot of volume or a lot of frequency. So a great example would be that this patient has had prior pregnancies and has a pelvic organ prolapse. And as a result of that is having urinary, frequent urination, but not a lot of it. Um, and you wouldn't know if the you wouldn't know if there's a volume or a storage issue. So if you're trying to ask what is the value of polydipsia here, polydipsia supports the notion that the urinary frequency the patient is experiencing is as a result of a large volume of urine, not of frequent urine, pushing the patient to compensate by drinking a lot of water to mitigate that volume loss. The only error in that statement is to assume that the polyuria is the driver of the polydipsia. It could be that this patient, like me, has an obsession with water and the polydipsia is driving the polyuria, and we'll have to find out. But that's what I would say the value of the polydipsia is it reduces the probability of pelvic disease and increases the probability that an endocrinologist may be presenting your case, not a urologist or any other person with expertise in the pelvis. I completely agree with you. And if you're trying to understand polyuria, you'd really say two words, two possibilities. Either the patient is drinking too much water or they have diabetes. And that diabetes could be mellitus or insipidus. So there's only really 3 possibilities. Patients drinking too much, they have diabetes mellitus, or they have diabetes insipidus. And I think your approach, practical, is superb. A simple test, one test, the urine analysis, can help you make tremendous progress. So to practice for that scenario, Bettina, where we're in clinic and all you get is a urinalysis, how might you get the most juice out of your urinalysis in a case like this? What might you look for? And some of it you've already mentioned.
I would look for glucosuria.
Excellent. And let's play this scenario out, Bettina. So the glucose in the urine is normal. Are there any other things on the urine analysis that you might find helpful in that scenario?
Um, Probably the osmolality or the urine
Exactly, yeah.
sodium.
Yeah, the specific gravity is your proxy for urine osmolarity, and that can be very, very helpful. So what this patient, you make tremendous progress on dipping this patient's urine in that urine dipstick can help you a lot. I think there's another dimension of this case to reflect on, which is how the breast cancer influences the DDX. But I know that Dr. Weber has 6 aliquots, so we've babbled enough for now. I'll pass the mic to him to tell us a little bit more.
I narrowed it down to 5, but all right.
Nice.
That was great. So the history she tells the PCP is that she's been thirsty for several months. She doesn't know exactly when it started, but it definitely had a ramp up about 3 or 4 months ago. She can't tell you a volume of how much she urinates, just like you said, but she says it's happening nearly hourly, even when she's trying to sleep. She also has blurry vision. She quenches her thirst primarily with Gatorade and orange juice. A little bit about her other issues. Her breast cancer is ER/PR positive, and it was diagnosed a few years ago, but she only recently started chemotherapy after some surgical interventions first. Her chemotherapy is letrozole, which I had to look up, is an aromatase inhibitor, and a drug called palbociclib, which I also had to look up, which is a cyclin-dependent kinase inhibitor. She has a history of type 2 diabetes, and 2 years ago had an A1C of 7. She hasn't really been following for diabetes in a few years because of all the breast cancer stuff going on, and she admits that she hasn't been the most adherent to her medications, and she has not been following a strict diet. She's gained some weight. It's hard for her to say how much. She's been pretty tired, and so she hasn't been exercising. Other past medical history for her, she also has hyperlipidemia. She has asthma. She's previously been diagnosed with a peptic ulcer, but no significant bleeding that led to that. For past surgical history, let me just see how we're doing here. Cholecystectomy. For her medications, she takes metformin, empagliflozin, which is an SGLT2 inhibitor, and dulaglutide, which is a GLP-1. She also takes atorvastatin and albuterol as needed. She denies any sort of supplements or over-the-counter anything. For family history, the only thing that was sussed out is that everybody in her family has diabetes. Her parents, all 4 of her siblings, and her 3 children with ages of 20s to 30s. For social history, she is a never smoker. Alcohol is rare, no illicits, and she works in a mail center. And why don't I give you the basic physical exam in the labs? So the blood pressure was 110/71. Her pulse, 106. Her respiratory rate was 18 and 97% on room air. Her BMI was 29. And a thorough exam is documented, but it all is just within normal limits. For her labs, a CBC is all within normal limits. For the BMP, I'll give you the specific numbers. The sodium is 138. The potassium is 3.6. The chloride is 104. The bicarb is 28. The BUN is 17. The creatinine is 0.81. The glucose is 229. A calcium is 9.0 with an albumin of 3.4. Her LFTs are within normal limits. Her A1C is now 12.4, and a TSH is 1.2. And I'll stop there.
Oh my gosh, Fatia, there's so much to think about
Yeah, I'm
here.
sorry, it's a big
Great.
aliquot.
Oh, I love it. Is this part of the condensing into 5, I'd imagine?
Yes.
So, Bettina, if we just go back to that original question about the polydipsia and polyuria, and if we follow that thread, I think there's a lot of other things that have emerged. But just to try to answer that question, how are you reconciling the data with your initial hypotheses?
Right. So yeah, I just want to say I had a lot of thoughts during the history, and then when the labs came in, it's like I had to rearrange them in my head again. So it's a really exciting case. So my first thought was that the patient is on an SGLT2, and I was thinking, it can cause polyuria, especially if the patient continues to take in a lot of sugars. So that will really cause polyuria in a patient. But with the patient's polydipsia, I would think that maybe there is another cause. And usually, please correct me if I'm wrong, but with SGLT2 intake, it doesn't really cause a lot of polyuria. It's just very modest. And, one big question I have when I heard the history of present illness is, why is the patient coming to us right now? Like, what change has happened? Because it's been happening for several months. And like, what's the big thing that happened now that made the patient come in today? Yeah, so that's one thing. And then another thing is that um, just a quick mention of the patient taking in Gatorade and orange juice. I'm not sure if those things can also worsen the patient's polyuria. So I'm just leaving it there, just in case, Rabih wants to talk about it. And then when I thought about the blurry vision, I was thinking about, if the patient has a history of diabetes, could it have been like a cataract or any diabetic retinopathy, which is a complication of diabetes, especially given the patient's HbA1c. But at the same time, I'm also considering maybe there is a pituitary mass. And I remember in just last week in a VMR, Ravi mentioned, when we talk about vision loss, we have to determine if it's really, the loss of vision or if it is a visual field defect. And I think being able to delineate that in this patient would be really important in guiding us towards the diagnosis. So yeah, and then with SGLT2, I'm also thinking about the possibility of euglycemic DKA, in which the patient has glucose of 229. So usually in DKA, we have above 250. So that's something that I'm also considering. So yeah, how about you, Rob?
Yeah, excellent. It seems, Bettina, that you've come to the conclusion that this patient's polyuria is the result of worsening diabetes mellitus, which I completely agree with. I think initially, the glucose of 229 made me worry that the patient, that a glucose of 229 alone may not be proportional to the degree of polyuria and polydipsia that she has. And so for a moment, I asked myself, wow, I've never thought of this in real life, but could this patient have diabetes mellitus and diabetes insipidus? And what would that look like? But I think when the hemoglobin A1C, which is a marker of your 3-month glucose control, returned at 12.4, which is very, very high, I think that while I'd still be curious to see if the patient has a low specific gravity on her urinalysis. Um, I think that the worsening diabetes mellitus is probably a very good operating work frame to explain all of the patient's symptoms. And I love what you did is you went back to everything in the HPI and said, can worsening diabetes explain this? And I love that you addressed the vision, because blurry vision in the context of diabetes mellitus is actually not uncommon, but it's usually the result of osmotic swelling of the lens. So last week we had a really great VMR that discussed the manifestations of diabetes in the eye. And unfortunately, in that diagnosis, it was a horrible infection of the eye directly related to the patient's diabetes. But in this instance, although diabetic retinopathy is the most common common long-standing ocular complication of diabetes, blurry vision without vision loss is often attributable to the diabetic manifestations in the lens, where the high glucose concentrations in the lens draw more water into the lens, obscuring the visual field. But when patients use words to describe their visual complaints, they may not be as precise as what the medical pathophysiology is. So blurry vision, if it's really just blurry with an intact visual field and intact visual acuity, is a lens problem. But blurry vision might be the patient's verbal manifestation of bitemporal hemianopsia, which would definitely be something that maps onto the pituitary. So that was really, really good conversation. I'm curious, Bettina, what in the context of worsening diabetes, What does the gained weight help? That's the other thing in red here. So let's try to reconcile that. When you're saying, hey, my patient's diabetes is getting worse and that they're gaining some weight, what does that do for you?
Um, to be honest, that's one thing that for me doesn't fit the story that I'm trying to create right now. Because usually I would think that in diabetes, the patients would have polyphagia and weight loss. So that's something that I'm trying to reconcile right now. But I'm thinking that maybe if the patient is gaining weight, it could be because of the fluid. But at the same time, the patient is excreting a lot of fluid. So I'm still trying to um, make sense of it in my head.
I'm so glad you said that. All too often, I think we try to fudge things and blur them together, but I agree with you. It's something that doesn't quite add up for me. Um, if we just review the pathophysiology of diabetes, what's happening when patients have a rapid increase in their sugar is their insulin is not working, either because it's deficient and not being secreted from the pancreas, or there's increasing resistance to insulin. But at this, essentially, insulin is not working, which is why we have to give the patient more and more and more of it. And when insulin is not working, well, I should step back and say one more sentence. Insulin is an anabolic hormone that helps you gain weight. And so when insulin is not working, you have less anabolic hormone and you should have increased catabolism, which should cause you to lose weight. And so this is a big source of confusion for a lot of us, and it's actually still a little bit of a confusion for me. So I'd love for Rob to correct me, and actually, I just love for your thoughts, Rob. So here's my understanding of the discrepancy. Um, the most of the discrepancy between when we say patients' insulin isn't working, so they should lose weight, but many patients with diabetes have a high BMI. And it's actually the notion that the high BMI drives the insulin resistance, which then drives less insulin to work. And so it's a little bit of a paradox where the very reason your insulin is not working is because of the increased adiposity. So normally, while you would expect all patients with worsening diabetes to lose weight because their insulin is no longer working, and that is a loss of an anabolic hormone. In patients with type 2 diabetes or insulin resistance, the very driver, the very reason their insulin is not working is often because of a high BMI and a high level of adiposity. Rob, anything to tweak there, correct there? Because I don't want to make a factual statement about something I'm not very sure about.
No, I thought that was perfect. In my mind, insulin has two jobs that I separate.
Yeah.
One is to prevent catabolism, like you're saying it's an anabolic, and the second is to control glucose. And sometimes those tasks are separated, as you can see in, for example, HHS, where there's no evidence of ketones. So catabolism is being inhibited, but clearly there's inadequate insulin to control the glucose, as opposed to DKA, where both jobs are failing. So you have ketones and inability to control the glucose.
Awesome. That's super, super helpful. Yeah, Bettina, so I agree with you. I think when you're saying the insulin's not working as well and the patient's gaining weight, um, you might wonder, well, does she have an insulin independent mechanism for her worsening hyperglycemia? And that's where you might wonder about things like Cushing syndrome or meds that she's taking, to start to say, well, her diabetes is getting much, much, much worse. Why is she gaining weight? And is it because it's not happening through insulin, but happening through cortisol, for example? So that's one thing we have to keep tracking. The other thing that I think is interesting to track is the family history. So what's your current model of diabetes as it relates to a family history? What's your understanding of this space?
From what I remember, I think it's type 2 diabetes that's more um, associated with the family history
Yeah,
compared to type
excellent.
1.
Excellent. Yeah, it's so counterintuitive. I had a hard time remembering this because we would say like type 1 diabetes is like this autoimmune attack and whatnot, and it seems so much more heritable. But yes, type 2 diabetes is much more heritable than type 1. And now, if you look at this family history, which was so expertly obtained in such rich detail that everybody is affected with diabetes, does that trigger, does that help you zoom in on um, more does that add nuance to the possibilities, you think?
Yeah, definitely. What worries me is the children, especially that at a
Yes.
very early age, they already have diabetes.
Yeah. Yeah, this I think this family history would raise the possibility of MODY, or maturity onset diabetes of the young, which is this really interesting intermix between type 1 diabetes and type 2 diabetes. Similar to type 2 diabetes, patients do not have autoantibodies to their pancreas. And similar to type 2 diabetes, there's a prominent, often deeply penetrant family history. But more closely to type 1 diabetes, the pathophysiology is impaired insulin release. And similar to type 1 diabetes, patients are usually affected at a younger age. Um, so here, the presence of this family history is very evocative of the possibility of MODY, of maturity onset diabetes of the young, of which there are many, at least 4 different genetic syndromes. And it's important to make this diagnosis for a variety of reasons. It changes your management in ways that are subtle and ways that are overt. So I would just pass on that teaching point that you made, that when there's a family history, think to type 2 diabetes, but when there's family history in all caps, not just a gentle one, think about the possibility of maturity onset diabetes in the young. So, Bettina, where are you interested in going next? Like we've talked about a lot, but what would you think would be your what are the questions that you're still wondering about that you would try to investigate?
Right. Yeah. So I'm really interested in the physical exam to see if the patient, well, first of all, the patient is dehydrated, and then to check what that blurry vision really means, because that would definitely change our trajectory. And then in terms of labs, I'm interested to see the urinalysis, as we mentioned earlier. And then also, I was thinking about the possible Cushings, maybe those are things that we can look into later on if we're not still happy with the labs that are the initial labs that come out after this.
I couldn't agree more with you. I'm right in that space, and I'll just show you visually where my mind is at. And this is a schema from the RLR website, RLR CP Solvers website. Um, I'll just put it up here, and without narrating it now, I'll try to narrate it in a little bit. But I think we're here, and we talk a lot about diet, we talk a lot about meds, and we worsening of the underlying disease. And in this patient, I think talking to her about her diet is going to be really important. She is on a lot of meds that I'm not very familiar with. So I would try to cross-check them to see if they're hyperglycemic medications. But we do know that she's not taking her medications as Rob outlined. So that'll be one thing to reflect on. But I think the other big picture conversation is, what is her actual diagnosis? Does she have type 2 diabetes? Does she have type 1 diabetes? Does she have MODY? And understanding her disease is probably really, really important. As you can see, depending on how long we're going to be talking about today, there's a whole other area to reflect on, including thinking about pancreatic issues, endocrine issues, or antibody issues. But the clue to the presence of these disorders is often the patient has many, many issues. The center of gravity is often very diffuse, in stark contrast to what this case seems to be so far, where the entire conversation is focusing on glucose and the consequences of glucose. But I think this is the visual map that I hope we're at. I hope I'm not leading us astray. And so I completely agree with you. Just to add for you, Bettina, Rob snuck this in, but he told us that the exam is completely normal. So thankfully we can file that away.
Oh, thank you.
Of course.
I'll
All
try
right.
to I'll try to answer some of your questions. That was great. Some of this is from chart review from the visit to the primary care doctor, but they said visual fields were within normal limits. She has no history of steroids, neither for her asthma nor for her breast cancer. A UA was not obtained, and I assume it's because she was on empagliflozin, so it would show glucose regardless, and she didn't have an anion gap, so I don't think they suspected ketones. And then I, like you, Robbie, am not familiar with these medications, but I did look up letrozole, and it can worsen your glucose control a little bit. So I think that's where we're at. So for the next aliquot, her diabetes regimen was intensified because of the A1C. She was started on basal insulin, glargine, as a first step, and told to keep a careful glucose log. Excuse me. In parallel, she received monitoring for her breast cancer, and part of that monitoring was a CT scan, which included the abdomen and pelvis. And it was with contrast, and what it revealed was a 1.1 centimeter adrenal adenoma. Since it was done with contrast, we cannot talk about the Hounsfield units. And I think I'll just leave you with that one.
Bettina, isn't it amazing when you get an accidental clue? And I know you're gonna you're probably gonna spew poetry on adrenal adenomas. I just wanted to say that um that whatever Bettina says is 100% true. And I will just start with saying, whenever you accidentally discover something like this case, always remember that you accidentally discovered it. And so while it may be very productive to your thinking in instances, most of the time an accidental discovery is a discovery you wish you never made. Truly an incidentaloma. But we're in VMR now, um, and um, and we're gonna listen to excellent thinking from Bettina, no doubt. But I just wanted to make that point. In most instances, an accidental discovery is one you wish you didn't make. But here it might be different. What do you think, Bettina?
Yeah, so honestly it threw me for a loop. So with adrenal adenoma, with that finding, I want to go back to the history and see if the patient has any other clues that can help us figure out if uh the patient's really having Cushing disease. And at the same time, I want to check the cortisol if it is increased, because maybe sometimes there is an adrenal adenoma but it is non-functioning, so I want to make sure that we're not um going to the wrong path. Yeah, because cortisol can cause hyperglycemia, but we don't want to anchor ourselves on that right now. So just really going back to the history, interviewing the patient again, seeing checking the physical exam if there are any striae, the classic signs, although I'm not so sure how frequent you really see that in practice. But and then also with the labs like urinary cortisol excretion, dexamethasone suppression test. So those are the things that I'm thinking of right now. So
Absolutely superb. And that's spot on. Bettina, and you're right. The vast majority of adrenal adenomas are non-functional. Um, and you always have to spend a moment thinking, could this be adrenal cancer? But the radiographic features of adrenal cancer are very evocative. And so, yeah, I think if this were a functional adenoma, you'd wonder, is this a aldosterone producing adenoma, a cortisol producing adenoma, or a an adrenaline or noradrenaline producing adenoma? And of those, aldosterone, cortisol, and epi and norepi, which one do you have the strongest association with causing hyperglycemia? What do you think?
cortisol.
Excellent. And any other ones you think can do it? Do you think aldosterone can do it or epi can do it?
I think I'm not so sure, but maybe epi.
Yeah, exactly right. Yeah, it can. You absolutely nailed it. Yeah, pure aldosterone secreting adenomas are unlikely to do it, but I think we have to spend a moment thinking, could this be a pheochromocytoma? And I think a lot of us disproportionately think about pheos more than their base rate because they can be acutely deadly. So I just wanted to make sure that that neuron of hyperglycemia and adrenal adenoma is mostly skewed towards Cushing's, but that you have a little bit of a light bulb that says, hey, this could also be a PHEO2. Let me review the patient's history for those kinds of symptoms as well, even though that's much less likely to present in more overt ways. And so, yeah, I think the evaluation of an adrenal adenoma, the first step is to get dedicated adrenal imaging, because dedicated adrenal imaging can give you tremendous insight into whether this is cancer or not, and it can give you information about what its status is. But yes, a functional analysis of this is definitely going to be very helpful. I'm curious, Bettina, what would you be looking for on exam now that there was a screening exam done without this history, but now that this history um, and now that we have this imaging finding, you might go do the exam again. So what would you be looking for just to pass on that teaching point there?
I guess for Cushing, the things that I would look for, and also for pheochromocytoma would be I would go back to the BP and also check and ask the patient if she's had any episodes of hypertension and headaches. I can see that the heart rate is a little bit elevated, so that could be one of the signs of it. At the same time, I'm also checking the skin, like for striae or skin atrophy, checking for the moon phases or the buffalo hump. But yeah, again, I'm not so sure if that appears in practice often. Those are just the things from step review. What else? I would check for muscle weakness probably. Usually, what occurs is proximal muscle weakness. So yeah, those are the things I remember about Cushing.
Superb, absolutely correct. Superb. Yeah, I think all those are probably very, very, very helpful. And all of those, Bettina, you can put into a column of anabolic and catabolic. Many of the sensitive things that are present in most patients with Cushing syndromes are anabolic things: weight gain, high blood pressure, lipodystrophy. It is the catabolic or destructive things that excess cortisol does that are very, very specific. So if you're trying to distinguish regular old type 2 diabetes from Cushing's, what you'd really look for is to see, are there features of destruction? And you said it, striae or loss of skin integrity, thin skin, and thin bones, osteoporosis. So thin vessels, thin skin, and thin bones have a much higher odds ratio of predicting Cushing's than separating Cushing's from type 2 diabetes. So I'd be looking for those things in particular. So I think the things that we're tracking, Bettina, are now we're like, this person has worsening diabetes, and there's something about her adrenals that is going on. And the other thing we should track is her prominent family history and try to see where all that lands. But I think the next step is exactly what you said, is what is the nature of this adrenal adenoma? All right, Dr. Weber, the mic is yours.
I love it. Great discussion. So basically, whenever there's an adrenal incidentaloma, there's a playbook to follow, which is just as you outlined, which is assessing for those 3 hormones. So let me give you those labs. And I'll specify that these labs were drawn at 9:30 a.m., which in endocrinology, we're very nitpicky about labs between 8 a.m. and 10 a.m., since some of these have circadian rhythm. So the renin activity level was 2.46 and aldosterone was 5. Both of those are normal. The serum plasma metanephrine was 61, and the plasma normetanephrine was 77. Both of those are normal. The AM cortisol was 21.5, and in our lab, anything above 20 is elevated. And the ACTH was 78, and in our lab, anything above 50 is elevated. So additional cortisol testing was performed. A 24-hour urine cortisol was 358, and in our lab, anything above 50 is elevated. And a 1 milligram dexamethasone suppression test was performed, which gave a cortisol of 1.9, which is just above 1.8, and a dexamethasone level was measured at 173. An MRI was performed and showed no lesions in the pituitary. And I will stop there.
What do you think, Bettina?
Right. So yeah, based on the labs, I'm thinking that this is Cushing's, and then it is ACTH dependent, which you can categorize further with possible that it's coming from the adrenal adenoma of the patient, and or it could be an ectopic ACTH syndrome like paraneoplastic. That's something that you can think about with a patient with cancer. So actually, I have a question. I'm not really sure about this, but would it be possible that the patient still has the adrenal adenoma that is secreting a lot of cortisol or ACTH, but at the same time, you also have an ectopic source as well? Is that possible to happen at the same time? So I'm just worried because this patient has breast cancer, and I want to make sure that it's something that's that can be ruled out. So yeah, that's where my mind is at right now. How about you, Rabih?
I'm in the same space you are. I think, there are three tests that help us diagnose Cushing's: the 24-hour urine cortisol, the midnight salivary cortisol, and the dexamethasone suppression test. The 24-hour urine cortisol is the most specific because it requires so much cortisol excess for all that excess cortisol to make it into the urine. So the fact that her 24-hour urine cortisol level is high renders a high level of confidence that this patient has Cushing syndrome. You often need multiple tests to be confident that the patient does in fact have this syndrome, because each test has imperfect sensitivity and specificity. But here you have two tests that are positive and one that is very specific. So I think you're absolutely right. This patient does have Cushing syndrome. And the question is why? The possibilities are the patient has ATH dependent or ACTH independent Cushing syndrome. And ACTH dependence is usually from the pituitary, but it can be an ectopic ACTH source. So here we have this adrenal adenoma. Most of the time, adrenal adenomas secrete cortisol, suppressing the ACTH, where you would get ACTH independent hypercortisolism. And herein is a trap, because you could just say this patient has cortisol, a high cortisol and an adrenal adenoma. It must be adrenal adenoma. Well, there's a theoretical chance that the adrenal adenoma could be secreting ACTH, and that's what's causing ACTH-dependent Cushing's. But here, in the context of breast cancer, you have to wonder, actually, is the source her breast cancer, and this adrenal adenoma is completely incidental and non-functioning? So all of our thinking hedges so much on the value of the ACTH, which is probably, in general terms, a test worth repeating, since so much of your thinking is dependent on it. But here, this combination of labs suggests the patient has ACTH-dependent Cushing's, which in most people would be from a eutopic pituitary source. But especially in a patient with metastatic breast cancer, you have to wonder, does she have an ectopic source? And so there's a few tests that can help you increase your suspicion of an ectopic source. But the first is to realize that when you have such a high 24-hour urine cortisol, so high, that's your first level. That's the first trigger of suspicion. But yeah, I am analyzing it the same way you do, Bettina. We have Cushing's in the context of an adrenal adenoma, and the instinct is to connect those dots. But what puts the brake on that connection is the ACTH elevation, which pushes us to consider other sources for the patient's Cushing's. Any thoughts or questions on that, Bettina, before we move on?
Yeah, I was just thinking maybe I kind of confused the ACTH dependent and independent. I think I was thinking more of it should be ACTH dependent is brain versus ectopic ACTH. I'm sorry about that one. Yeah, and I'm curious to see, maybe further imaging on the chest maybe would help us also if we're looking for an ectopic source.
Superb. I completely agree. All right, Rob, the mic is yours.
All right. I love the discussion. You're right on. So this is the last aliquot before I give you the conclusion. So from her outside doctors, based on her dexamethasone suppression test, which was 1.9, not that high, she was diagnosed with MACS, MACS, which is the disease formerly known as subclinical Cushing's, and told that the primary treatment is lifestyle modification, but potentially taking the adrenal gland out down the line if she developed complications. She came to us for a second opinion. So I had the luxury of having all of this data when I saw her, which makes things much easier. And I got some additional history. And she said, if you touch me lightly, I bruise. I have a dog, it jumps on me, I bruise. And why, yes, my face is much rounder than before. And it's actually, when I look back in the pictures, that's been going on for years, even before the breast cancer. And my hair has been thinning, but I attributed it to the chemotherapy. And on exam, she is an obese woman with very centrally located adiposity. She has what we call supraclavicular fullness, which means the clavicles are kind of under a mound of fat. And she has a positive dorsocervical fat pad, which is what we used to call the buffalo hump. She does have striae. She has thin limbs, and she has a little bit of weakness in her thighs, but not enough that it affects her ability to stand or to ambulate. She does have intact visual fields, and at this point, her vision is not blurry. I saw her in the afternoon, so I sent her right to the lab. And so these labs at 3 p.m. revealed an ACTH of 64, which again, anything up to 50 is normal, but above 50 is elevated, and a cortisol of 18. And then a diagnostic procedure was performed. And I'll leave it.
Dr. Weber, amazing. Bettina, I think that your exam hypothesis, I just wanted to emphasize that, like your exam, a detailed, thorough exam that you outlined in high level detail was just so precise. So kudos on that. What are you doing with this data?
To be honest, I've never heard of Max before.
Yeah.
I would love to read up on it after.
Yeah.
But I was thinking like I'm really glad we went back to the history and physical exam so that we can get more confirmation of the patient's condition. So yeah, that's what I'm thinking right now.
Yeah, no, absolutely superb. I think
Mm.
Max is basically the I view it as, and I'm sure Rob has a more nuanced view it as the is basically the cortisol equivalent of subclinical hyperthyroidism, where the patient has low grade secretion of cortisol enough to cause mild symptoms, but not from a focused but not in a level that becomes overt. And I think the additional data that you have is that the patient has overt signs of Cushing's syndrome, with the striae and the fat redistribution, making mild autonomous cortisol secretion an unlikely diagnosis because the patient has overt evidence of cortisol excess um, on her exam. So I'm curious what you think of the data here, because we have a high ACTH and we have an MRI without any lesions in the pituitary. So where are your thoughts going as to how we can get to the bottom of this?
Right. Yeah, I'm still thinking of ACTH dependent causes, especially leaning more towards ectopic right now. So I would really want to get imaging on the chest. I don't know the utility of like PET scan or any other like functional imaging for the patient, but if those would be helpful, I'd want to get those too.
I completely agree with you. I think that, we can now, as we said, we got to confirm that this is ACTH dependent with a repeat ACTH, but we are absolutely in the world of ACTH dependent Cushing syndrome. I'm just going to pull up a visual to help guide us. Um, Give me one moment. Sorry, I should have done this earlier, but I think it's such a complicated space that I think a visual would be really, really helpful. Okay. Um, Sorry. Okay, here we are. Oh, nope, wrong one. Haha. There we go. So, this, sorry for borrowing the screen. So we're on this journey for Cushing's, right? And we've already done this part where we suspected it. We've now diagnosed it. And just to emphasize how the more specific, that 24 urine cortisol is just so powerful. So in most people, actually, exogenous steroid intake is the most common cause of steroid excess. But we've proved that that's not at play here. Even though we haven't heard about the most thorough history, but the fact that the ACTH is elevated excludes exogenous as the cause, because exogenous steroids would suppress the ACTH. So here we're either dealing with pituitary or ectopic. And look at this, Bettina, there's an 80% chance that this is pituitary and only a 10% chance that it's ectopic. When you think of ectopic sources of ACTH, Bettina, what cancers have you been taught to think about the most when you think ectopic ACTH?
Oh, the first one that comes to mind is lung cancer, like small
Yeah, exactly.
cell.
And
Yeah.
that's why you really want that CT chest. You want to make sure the patient doesn't have a synchronous small cell. Now, the question for you to grapple with, Bettina, is we heard from Rob, he kind of snuck this in, that the patient had these kinds of changes even before her breast cancer history. So what do you do with the hint that this syndrome has been at least years in the making? Does that push you more to ectopic, or does that push you more to pituitary? What do you think?
Oh gosh. I would probably think that it's more pituitary just because it happened before the breast cancer. But I'm
Yeah.
also not sure if the patient has another type of cancer. I don't know if I'm just confusing myself.
Oh, hey, no, you're not at all. That's absolutely right. Ectopic Cushing's is usually in the context of poorly differentiated cancers that are fairly aggressive, but that's not always true. It can occur in carcinoid tumors or more gentle tumors. But the long-standing ACTH dependent Cushing's is a further support for the pituitary hypothesis. So if you start with 80% chance of pituitary when you have ACTH dependent, 80%, and then you layer on long-standing, that should make it even higher. But then, Bettina, I think the reason that you're like, wait, Robbie, what's going on is Rob told us the MRI showed no lesions in the pituitary. Well, the fact that I will arm you with is that is not perfect. That I think it's up to 5 or 10% of MRIs will be negative, but the patient will in fact have a microscopic pituitary focus. So if you had to get creative, Bettina, of like saying, I'm going to pursue the pituitary despite the negative MRI, have you heard of any tools or tricks that you can use to pursue the pituitary hypothesis even with a normal MRI?
Yeah, I think I remember when the MRI is inconclusive, you can do the inferior petrosal sinus sampling.
Yeah, I will stop talking and pass the mic to Dr. Weber to see what he has in store.
Great. Well, petrosal sinus sampling was performed. And how to interpret this is, to put it as simply as possible, there is blood drawn centrally from the petrosal sinus veins, and then there's blood drawn peripherally from say, an antecubital IV. And you're looking for a ratio greater than 2 to say that it is central from the pituitary. In this patient, her ratio was 23. And an MRI was repeated at our institute, which has a bigger magnet, and so we get more resolution. And actually, it did reveal an adenoma in the pituitary. Pretty small though, 5 millimeters by 5 millimeters by 3 millimeters. So a diagnosis of Cushing's disease was made. And I could give you a little bit of the outcome if you'd like. Go for it.
Why don't we just give Bettina a round of applause for
Yeah.
nailing the diagnostic procedure? That was amazing, Bettina. Really nice job. Yeah, Rob, tell us what happened.
Yeah, so we sent her to neurosurgery. They did a transsphenoidal resection. And intraoperatively, they said it was a great case because the tumor was encapsulated in some sort of pseudomembrane. So it all came out in one contiguous piece, which they said is not always the case, but they felt very confident that they got all of it. And it had the same dimensions as was seen on MRI. In pathology, it was stained for all of the pituitary markers, and it was 100% of the cells were strongly positive for ACTH, and none of the other stains were positive. So it was very clear case. The key 67, which is a marker of mitosis, was only 2%. So that put this patient in a low risk category for recurrence. And her morning labs the day after surgery showed an ACTH of 9 and a cortisol of 0.9, which tells us that number one, they got it, and number two, there's still enough ACTH remaining that there's probably some viable pituitary remaining. So she was started on glucocorticoid replacement, and she said she just felt like a feeling of heaviness that she'd had for years had been lifted off of her, and that she could sleep better at night. And now we follow her in the outpatient setting to wean down the glucocorticoids.
Rob, I just want to be able to get so much learning out of you from this case because I think you have a lot to teach us. There's such a fascinating journey and honestly such a great pickup of a diagnosis that probably went under the radar as the patient got diagnosed with a very morbid metastatic breast cancer, and to swoop it out and to remake it is really a tremendous feat. But Bettina, I just wanted to say that I kind of kept a little quiet and pushed you really far in this case. I think to be able to have a conversation about advanced interpretation of endocrine labs is really tough. But from the moment you heard polyuria and polydipsia, you said diabetes. And from the moment that we had the A1C in the context of weight gain, we had to pursue a non-insulin mediated hypothesis, which Cushing's came to mind. And that's when you emphasized the exam is going to be so key and didn't overlook the fact that an exam was done without a pretest hypothesis. And your eye will not see what your mind is not looking for. And when you're looking for Cushing's, all of a sudden that striae that's on the flank that you didn't look for is now more apparent. And but what was most impressive for me to watch somebody who is in their early training to not rush to say Cushing's and adrenal adenoma, they have to be related. And if you listen to your conversation again, the amount of training that you've had to do to your mind to not reflexively say that was incredibly impressive. And then the final moments where you were confident about what the next step was, despite the normal MRI, was really cool. So kudos on an incredible job. And before we hear from Rob, the learning that he has for us, I'm curious what this journey was like for you.
Yeah, thank you so much, Dr. Weber, for the incredible case. First of all, I just want to say that I'm glad the patient is okay. And secondly, it was really an amazing journey for me. I feel like I went through the whole algorithm of diagnosing Cushing and going through all of the possible differentials. So that was really fun to revisit from my review from before in med school and in STEP exams. And I also just wanted to say that I think this one is a really good example of how we keep on asking questions to get to the bottom of things, figuring out what fits and what doesn't, and understanding why some things don't fit and how that would push us to investigate for us to further our learning, but also for the patient, as you can see in this case. So yeah.
Well said, Bettina. Such little about your diagnostic wizardry. That's all your humility, but I completely agree with everything you said. Rob, what do you feel like you learned from this case? What do you want to impart us with?
I feel like as Austin is raising in the chat, like how would we have made progress here without the adrenal adenoma, and we kind of like stumbled to victory here. And I don't know, it made me reflect on that a lot of her visits took place over Zoom. And I feel like possibly there was not a very thorough physical exam. And I think it speaks to the power of the physical exam, but that's, speculation. I don't know for sure. I think two things for this case. I've seen a lot of patients with Cushing's who are diagnosed with something else, and it just takes a long time to make a diagnosis of Cushing's. The other one that comes to mind is a young woman who was diagnosed as manic because she just like didn't need that much sleep. But or I'm sorry, she was diagnosed as bipolar, but she never had the depression, and it turned out she had Cushing's. And then the second thing that I reflected on this case was you really can't trust those MRIs. I've seen a few cases now with MRI negative, so let's look elsewhere. And then I don't know if it's just that we have a stronger magnet or we do the contrast differently, but sometimes we do see the lesion when it has been not seen on another MRI. So it really, I would not rest on an MRI negative finding.
Amazing. I couldn't agree more. I think I really have a hard time diagnosing slowly progressive diseases over time. They can blend into the patient's normal and make it really, really hard to diagnose them. So it takes a very, very astute clinician like yourself. And I'm glad that she got that second opinion, because clearly it helped change her life. So thank you for waking up at 6 a.m., which you probably do anyway, but instead choosing to spend that hour with us. We learned a lot. I'm really, really excited to kind of hit the highlights on the teaching points through Mariana.
Thank you, Dr. Weber, for this fantastic case, and congrats, Bettina, for nailing it. And let's go ahead with some teaching points. So we had a patient with polyuria and polydipsia, and we have to think about increased osmolality causing diuresis, and also deficiency of ADH or increased water ingestion or diabetes. And it's also important to discuss polyuria plus polydipsia versus polyuria alone, because polydipsia added shows that polyuria is real and supports the notion that polyuria is due to increased volume instead of increased frequency. And polyuria alone would make us lean toward to urinary causes. And we also discussed medications causing the polyuria here, and we could have the SGLT2 that we know that is known by causing polyuria, and also a glycemic DKA, and at the same time letrozole that the patient took for a while could be disturbing glucose control. But the patient also had blurred vision, and we discussed the possibility of cataract, diabetes complication, osmotic swelling of the lens. But we also had glucose of 229. That is not that high. So we could be diabetes insipidus causing polyuria. And the patient also complained about weight gain. So we discussed volume excess and the controversial insulin role in this case. We know that insulin is an anabolic hormone that has two main functions, that is prevent catabolism and control glucose. An example of that is that in HHS, that we don't have like total lack of insulin. We have no ketones, but we have inability to control glucose. And also in DKA, that we have like lack of insulin, we would have ketones and inability to control glucose. So it's also important to discuss the role of insulin deficiency in this case. And we on follow-up, we had a CT that showed adrenal adenoma, and we need to make sure that it's active, because the majority of them are not functional. And to do that, we could do like a 24-hour urinary cortisol, or a salivary test, or a dexamethasone suppression test. And we could have like different types of hormone production with adrenal adenoma. That could be aldosterone or cortisol or epi, non-epi. And increased cortisol and pheochromocytoma could be causing the hyperglycemia shown in this patient. And it's also important to look for Cushing syndrome signs in the physical exam. Anabolic signs would be weight gain or high blood pressure or lipodystrophy, and catabolic signs would be osteoporosis or thin vessels and thin skin. And with more data, we found out that this patient had like thin vessels because she had a lot of bruises easily. And with more labs, we found out that this increased cortisol was ACTH dependent, and we could have a pituitary source. But in a patient with past medical history of breast cancer, it's also important to investigate another sources, such as a paraneoplastic syndrome. But with more data, we found out that this was happening for a long time. So, and when we have a long-standing ACTH-dependent cortisol-producing adrenal adenoma, we will probably have a pituitary focus. So even with a normal MRI, we should investigate this patient. And with that, we had the final diagnosis of Cushing's disease due to pituitary microadenoma. Thank you so much for this case. It was amazing to be part of that.
Mariana, there's somebody here with a message for you.
Hi, Mariana. I am Rabih's mom. You did such an amazing job.
She also says, I have osteoporosis too,
Yeah.
in the middle of that conversation.
I do.
Yeah.
Okay.
She learned a lot, Mariana, from your great teaching points. Thank you so much. Oh my God, sorry, I can't hold it together. She was just like right here, like nodding to your excellent teaching points. All right, y'all have a great rest of your day. Thank you, Rob. Thank you,
All right.
Bettina. See you all around.
Thank you. Bye.